Chapter 10 discusses respiration, artificial ventilation. As always, we're going to start with the physiology and pathophysiology. We're going to discuss respiration, what is involved in positive pressure ventilation, oxygen therapy, and then we're going to discuss some special considerations, and we're going to touch on if you need to assist a paramedic with endotracheal intubation. They're going to cover some points that you could do to help out that situation. So ventilation, we already know from A&P, chapters in A&P. Ventilation is just that process of moving air in and out of the chest, right? Inhalation, exhalation. Inhalation is active, the chest muscles expand, the diaphragm contracts. We have negative pressure that pulls that air into the lungs for that oxygen exchange. Exhalation is passive, okay? So we exhale, the chest muscles and the diaphragm start to relax, the diaphragm goes back up to its original position, and the positive pressure pushes that air out of the lungs. Tidal volume, remember that being the amount of air moved in one breath, okay? The volume of air in one inhalation, exhalation process. And then your minute volume is the amount of air moved, so your tidal volume, per minute, so number of respirations. Your ventilation is designed to move that air to and from those alveoli. Not all of the air that you breathe in reaches those alveoli. It's occupying what's called, the term for it is dead air space. Alveolar ventilation is just that, okay? How much of that air reaches those alveoli for that gas exchange? You know those alveoli are the little cauliflower sacs right at the end of the bronchioles, and they are responsible for that oxygen carbon dioxide exchange. The pulmonary capillaries bring the blood close to those sacs, and then alveoli, oxygen in the alveoli moves the blood, and then the carbon dioxide in the blood moves into the alveoli, so it's a full exchange. They touch on this area of diffusion, moving that gas from an area of high concentration to an area of low concentration. So if you hear the term pulmonary respiration, it's the diffusion of oxygen, carbon dioxide between the alveoli and the circulating blood, okay? That's pulmonary. Cellular respiration is the diffusion of oxygen and carbon dioxide between the cells and the blood, okay? So pulmonary respiration, we're dealing with the alveoli and the circulating blood. Cellular respiration, we're dealing with the cells themselves and the circulating blood. So in order for both of those functions to occur and function properly, the respiratory and circulatory systems work in conjunction, the cardiopulmonary system. Remember, I said the heart and the lungs were married, so one supports the other and vice versa. It may be called the VQ match or ventilation perfusion match. It's just all about balance, guys. It's all about making sure that pulmonary and cardio systems are working together, that we're getting homeostasis accomplished. If either side of that system fails, the cardio or your pulmonary system, the process of respiration is compromised. So mechanical failures, stab wounds, right? We have something that somebody gets stabbed in the chest, air from the outside gets into the cavity. So we can't create that negative pressure balance. Air gets in there. It's not part of our normal respiratory process to come from that way, right? We breathe the air in, negative pressure goes into the lungs for that gas exchange. Chest wall injuries limit that chest wall movement. So you have fractured ribs. Your patients are going to be in extreme pain or a lot of pain. If you've ever cracked a rib even, you know it's painful. And so for them to breathe in the volume that we need to do that gas exchange and that negative pressure to happen gets compromised because of that pain. So that can create some issues. A patient like that, I would be maybe calling for some support, see if we could get some pain meds on board so we can restore that volume. Any airway problems, bronchoconstriction, asthma, COPD, any of those diseases, allergic reactions that are going to limit airflow is a compromise. So interrupted gas exchange, we can't, your oxygen and carbon dioxide exchange is not going to be adequate. So low oxygen level, okay? The wildfires in California right now, I'm sure, are limiting. Even the normal air is 21% oxygen. I'm guessing it's lower than that in those areas that have been hit by fire. So diffusion problems. So we have something going on in the diffusion, whether it's pulmonary or cellular. The alveoli don't work properly, and therefore, they're compromised, so they can't do that gas exchange adequately. Circulatory issues, significant blood loss. Okay, we have trauma, something happens internally, externally with blood loss. It's going to reduce the amount of blood circulated to those alveoli. Insufficient hemoglobin, people that are anemic, hemoglobin that's not working properly, sickle cell anemia, limits that transport of oxygen, everything's going to get compromised that way as well. So when we talk about respiration, it's all about balance again, adequate, inadequate breathing. So the brain and body cells, we know they need a steady supply of oxygen to maintain normal function. The term hypoxia, hypo being low level of oxygen, hyper meaning high, capnia is a high level of carbon dioxide. So we assess this cardiopulmonary system, we see how well it's oxygenating, how well we're getting rid of that carbon dioxide. So when something goes wrong, the body does try to fix itself or compensate for it. Chemoreceptors, they'll stimulate that respiratory system to breathe more rapidly, right? We don't have enough oxygen. We have too much carbon dioxide. It's going to start speeding up your respiration rate, the respiratory rate. The respiratory rate speeds up. The heart rate is going to speed up as well to try to compensate as those vessels start to constrict. So when you have a patient in respiratory distress, your compensatory systems are working. You're seeing normal mental status. The skin looks relatively normal. Pulse oximetry is relatively normal. It could be just a little bit low. They're just short of breath, okay, respiratory distress. However, when it gets to the point of respiratory failure, our body's compensatory systems aren't able to keep up to maintain that balance. And so your body's needs aren't met, and it's going to proceed into respiratory failure. So respiratory failure is when the body's no longer able to compensate. You're seeing pale skin, cyanosis, altered mental status. Your pulse oximetry reading is getting lower. And if you have a patient that is to that point when you get there, you need to intervene and get oxygenation and even possibly ventilation started because it is a precursor to respiratory arrest. Respiratory arrest means arrest is stop. So a respiratory arrest means your patient's not breathing anymore. And that's pretty much what I already discovered, inadequate breathing. So as far as assessment process goes, all right, is the patient breathing or not? That's a good place to start. Second, is the breathing adequate or inadequate? So adequate breathing, we look at that. Equal expansion of that chest seen when they take a breath in. Air is heard or felt moving, the nose, mouth, chest. Skin has normal coloration, so pink, warm, and dry. Rate, rhythm, and quality and depth are typical, right? Rate is within those ranges. Your rhythm is regular. Your quality, you're getting clear lung sounds, no wheezing, nothing like that. And then that volume in and out is adequate. Inadequate breathing signs. Mental status is altered. Chest movements, absent, very minimal, uneven. You see a heart rate that's slow in your kids, That is not normal. Your breathing movements you're looking at, and they're breathing from their belly. No air is felt or moved at the nose or mouth. Breath sounds are diminished or even absent. Any sounds, you know, we've already discussed this when we talked about airway management. We don't like noisy breathing, so anything that's making noise, we need to figure out why, and we need to supplement or try to fix that. Too fast, too slow of a rate. Shallow, very deep, long inspiration in. Labored breathing. Cyanosis, that bluish color in the skin, lips, tongue, ears, nails. And like I said, that inspiration or expiration is too prolonged. Patient can't talk to you without interrupting sentences. Retractions, so that muscle retractions, you're seeing the muscles pull in. Nasal flaring in your kids. Your oxygen saturation readings are low. This is saying less than 95. We know that we like to have that less than 94 is kind of the gold standard now. And any body position that indicates distress, right? So they're in the tripod position. They're working hard to get comfortable. They're sitting straight up. Any of that is indicating inadequate breathing. So we already talked about hypoxia, hypo meaning low oxygen, and supply, insufficient supply. So, you know, if they're in a fire, of course, if they have COPD, emphysema, chronic bronchitis, any of those diseases, an overdose, okay, on a drug that depresses respiratory. So your opiate overdoses, it's going to affect their respiratory drive. Heart attack, any cardiac compromise, stroke, embolism means a clot. Signs include, big ones are cyanosis, altered mental status. So address that cause, get your oxygenation started. If they are breathing inadequately, and our big thing with the bag valve mask to provide artificial ventilation, breathing too fast, too slow, not breathing deep enough, you're going to need to provide supplementary oxygen and ventilation to those patients. Non-breathing patients, pretty common sense that you're going to do those breaths for them. You can provide supplemental oxygen to your breathing patient. You have nasal cannula, you have non-rebreather based on the rates and what you're seeing on your patient to determine which one will be best for that. Keep in mind that you see patient with those signs and symptoms, you need to intervene because it's going to get worse before it gets better. So it's better to be too aggressive on those oxygenation procedures than not aggressive enough. So positive pressure ventilation, when we did airway management, we talked about that bag valve mask used when we have inadequate breathing or, of course, not breathing at all. So the positive pressure relies on a force that's exactly opposite of the force the body uses. We're going to force that oxygen in to that alveolar level. There are negatives. There are some side effects you got to watch for. Keep in mind, you are pushing air into the thoracic cavity. It can affect the cardiac output because the heart can't expand like it wants to refill chambers. So it could cause a blood pressure drop. So make sure you watch that. Gastric distension, if we overventilate, can cause air to be diverted into the stomach. Okay, so if you're seeing that distension starting on these patients, you're overventilating. That's the main reason why and in cardiac as well, that when we're ventilating, it's only to chest rise. We don't have to force that thing. We don't need to push that thing to its limit. We only need to push the bag valve mask to the point we get chest rise. If you ventilate too often, okay, so for an adult, for example, once every 6 seconds, nice and controlled, you decide you're pretty excited that day and you're doing one every 2 or 3, you've just blown off too much carbon dioxide and they could lead to vasoconstriction. So we need that carbon dioxide. It's a nice balance, but if you hyperventilate your patient, we're going to have secondary issues. So when we talk about artificial ventilation, you do have the mouth to mask, right? That's that in CPR, you have that mouth to mask. You can actually place that right on a patient's mouth. There's a valve so you don't get any infection, anything that comes back at you. Your 2 respirator bag valve mask. So when we've got one person that's using both hands to support that mask while you ventilate. 1 respirator bag valve mask, you're doing it on your own. We know we can't ventilate patients that are vomiting, have any blood, vomit, anything in the airway, because then you're going to push it into the lungs and they'll aspirate, and that is not an optimal outcome for them. So to ensure you're doing a great job, watch the chest rise and fall. Make sure your rate is good. So remember, the scenes that you are on are high stress scenes. Count out loud. There's nothing wrong with that. Once every 6 seconds is adequate in adults. Once every 3 to 5 for your children, and then once every 3 for our little infants. So if you have a problem seeing that chest rise, reposition the head. Try to do your head tilt chin lift again, or your modified jaw thrust, and try to get that where you're seeing that chest rise again. If you have a patient that's breathing too fast, okay, too fast, you want to explain what you're doing. You're going to try to get them to slow down. Don't overlook trying to get the patient to slow their breathing rate down on their own before using the bag valve. Telling them, okay, I need you to slow down your breathing in through your mouth, or in through your nose, excuse me, out through your mouth, in through the nose, out through the mouth. When the patient breathes in, squeeze the bag, okay? Breathe in, squeeze the bag, and hopefully that will get them to start slowing their breathing down. If they're breathing too slowly, once again, if they're still alert, talking to you, explain what you're doing, tell them that they're not getting enough oxygen in their body. You're going to add ventilation in between the patient's own. So that means if your patient's only breathing 6 or 8 times a minute, you're going to provide some ventilatory in technique in the middle. Okay, so if they're breathing real slow, you're going to want to make sure you get 10 to 12 breaths in total per minute. So techniques: open your airway, suction, position the airway so you're going to get good ventilation. You're going to sniffing position, like when you're sniffing the flowers, you want to tilt their head back just a little. You don't need to go very far back. Adjust your padding. Okay, so you remember your pediatric patients are a little challenging, so putting a towel underneath their shoulders, bringing that up into the neutral position is probably going to help you get good ventilation. Obese patients, if you've got to kind of come back a little bit just to get that neck back into a good position, you can certainly do that. You need to, any suspected spinal injury patients, we're going to do modified jaw thrust, and you're going to try to ventilate in the neutral position as much as you can. Proper seal takes a little bit. It takes a little bit of practice. We kind of already went over this in skills, where you can move your hand into that CE position if you're doing it by yourself. 2 hands, if you've got somebody, especially on scene, that can hold the mask with both hands while you get the ventilatory process started, even better. So even if you aren't going to be able to take that person with you en route, if you get some really good 2 respirator bag valve ventilations going on, that's going to speed up the oxygenation process. So beards are kind of an issue. We'll try to work around them as best you can. You could try to wet them down. I have never seen that really work, but do the best you can. Dentures should be left in place. We already discussed that, unless they're creating a problem, or they're loose, or they're impeding the airway. Otherwise, leave them alone. They're actually helping you out. Using an airway adjunct on unresponsive patients can certainly help your ventilatory process, keeping that tongue down. So mouth to mask, I will tell you, you're not going to see this in the field very often. You're just not, we just don't use the mouth to mask. It's much better to use. If we're going to have to go to that point to ventilate a patient, they're better with that bag valve mask to get that positive pressure to make sure that that oxygen is getting where it needs to go. And there's your pocket face mask. But you know, if you're out on a hike someday and somebody drops in front of you and you happen to have it with you, there you go. You can start ventilating. So there he is. And you can use, the masks nowadays have an oxygen port. So you could do that if you had those. But like I said, I'm going to tell you, you're not going to see that very much in the field. You're going to see those bag valve masks. So these bag valve masks, they do come in adult, child, and infant sizes. Make sure that you're using the proper size for your patient. They have a little self-refilling shell. They have a valve, and they have the oxygen inlet, 15 liters per minute, high flow. There's your different sizes. Oxygen, we turn that on, enters that reservoir bag. When squeezed, that oxygen that's in there gets delivered directly into the patient. When released, the patient exhales and oxygen enters the reservoir. And we will go over this in skills. There's the two rescuer bag valve mask delivery. See how we've got two hands on there, creating a way better seal than with just one. So if it's possible, even if you have a police or first responder on scene, you can certainly teach them how to do that and hold that so you can get some good ventilation. They're doing the modified jaw thrust method. One rescuer ventilation. If you're by yourself and your partner's got to drive, you're going to make a C around that ventilation port, and you're going to make an E with the other three fingers. So there it is, the nice C between the thumb and the index finger, and then the E around the chin. Be careful on those fingers around the chin that you're not going too far and choking your patient. Make sure you just stay on that bone, on that chin line. You can come up farther if you're having some trouble with the seal. People with smaller hands tends to be a little bit of a challenge for us. You can come up farther on that mask and push in the plastic area, and you might be able to get a better seal. BVM will be used during CPR. All right, so stomas, if somebody has a stoma, you're going to use a pediatric mask with an adult bag valve device, okay? Pediatric, just the mask only, because the mask fits around that stoma perfectly. Ventilate like you would once every 6 seconds, once every 3 to 5 with kids. Be careful watching your chest rise, just like you would if you were ventilating a normal patient that did not have a stoma. The things with the stoma, the trachs, make sure you have your suction device with you. More than likely, you're going to see a lot of mucousy junk, and you need to clear that out so they get good ventilation. Ventilators, you might be assisting with ventilators. This is something that is usually on the paramedic level because we have to set minute volume and we have to set tidal volume on it. And that's what it looks like, right? So basically that's your portable ventilator. So just like everybody's going on ventilators, right, for COVID. Okay, not everybody, for a lot of people. So it's a machine that breathes for them, right? Gets the correct tidal volume, gives them the oxygen, gives them the correct number of breaths per minute. But you might be assisting with this, so just be kind of familiar with it. It's the portable version of a full hospital-sized ventilator. All right, so oxygen therapy. Oxygen is a drug. It can cause harm, but for the most part, we want to determine our oxygen administration based on our findings. So saturation's below 94%. We don't like that. Hypoxia, of course, we don't like. Cyanosis, decompensation, right? They're breathing too hard. Their heart rate's too hard. We want to make sure that we're getting proper oxygenation, but just respect oxygen. It takes a lot to over-oxygenate somebody, but that's why we kind of shoot for that 94% kind of guideline. Make sure you're ventilating your cardiac arrest patients, right? You need to get that oxygenation with them going to keep that going. Most systems, we have cylinders, pressure regulators, and of course the delivery device. Your cylinders come in various sizes depending. Your D cylinder is the smallest one, goes way on up to an H level. And they're green or green and white. So this one right here is probably, I'm guessing that's an M cylinder. Those are big, those are the ones that are basically feeding the ambulance ports for oxygen. Your smaller ones, your D and E, are more common on the cots in your jump bags. When you're working with those cylinders, remember that's pressurized gas. You need to have a hand on that at all times. Use proper wrenches. Medical grade oxygen always. So you have air gas or Praxair, someone comes out and takes care of switching those cylinders out. You're going to test the tank, make sure that you're blowing out all the junk that it was on the truck when it got delivered, and you're making sure it's pressurized. The cylinders need to be stored in cool, ventilated area. They always need to be secured. So they are in a device that they're secured, or if you are switching out oxygen tanks, your hand should be on that tank at all times. We don't leave cylinders upright non-attended. We definitely cannot smoke. Your patients like to try this though. So if your patients are smoking when you get there, there's no reason that you, it's not rude to consider to tell them to put their cigarette out. They can. There has been incidents that patients have actually had cylinders blow up because they're smoking with their oxygen on. I'm not making it up. Serious. Anyway, so grease, oil, fat-based soaps, tapes, medical tape, nothing on a cylinder that's going to cause it to possibly react. Don't drag the cylinders. Don't roll them on their bottom. You need to carry it both hands, keep it secured, or keep it in a roller cart secured. So there's your D&Es, more commonly what you're going to see on ambulances other than the main tank. Should be properly supported. They should be in the horizontal position. You do, if you want to change out the cylinder and upright, just make sure your hand's on it. And as far as the flow meters, we'll go through that Driggs skills, showing you the regulators, the flow meters, and how to read those PSIs. There they are right there. Low pressures, constant pressures. It's going to measure how much oxygen you have in the tank. Your regulator on the side there, that black knob, is going to be able to set your liter flow. There's the high pressure flow meters, and that's going to be your pretty common, you're going to see on your tanks that are on the cots or in your jump bag. To the high pressure that they're showing you, I'm sorry, is that screw top, that little, the one that has grooves, the threaded connection. Most of the time though, our tubing is going to go to the right of that, right where you see that 0, right below that. And then where that 0 is where you're going to set your liter flow. So it'll go all the way up to 25 if you wanted to, but you're never going to use 25. But we can have humidifiers connected to these. You're not going to see them in ambulance. If you work in an ED, you will. Humidified oxygen benefits, especially like croup. Transports are usually short and it's just too hard to carry these things. But if you have humidified oxygen, that's what it's going to look like. It's going to be that sterile water attached to that port. Medical hazards, we don't usually see this. Like I said, oxygen toxicity, air sac collapse, we don't usually get a patient to the point of that. Usually patients, when they're calling us short of breath, they do need the oxygenation that we provide. Infants, be very careful with, especially with masks. The bridge of the nose doesn't always fit the greatest, and you can damage the eyes by giving positive pressure ventilation. So be careful on the bridge of the nose there. Make sure you're protecting their eyes. Supplemental oxygen, shortness of breath, hypoxia. So what do I do when? Well, it depends on what your patient's presenting like. So mild distress, I would start with a nasal cannula. If you get someone that's pretty short of breath, still breathing volume and with pretty close to the normal number of times per minute, get your non-rebreather on, start coach breathing them. And your guidelines are going to provide you some guidance as well. Your non-rebreather is the best way, of course, to provide that high 15-liter flow to breathing patients. You need to make sure that reservoir bag is filled before you put it on the patient's face. We set it at 15 liters. There's some flutter valves on the side. That's why it's called a non-rebreather. So the flutter valve is going to allow that carbon dioxide to escape the mask when they exhale. So it's kind of giving you some guidance there. Patients with hypoxia and shortness of breath, chest pain, altered mental status, any of those, you should be throwing a non-rebreather on. So there's your non-rebreather. Note those little flutter valves that allow that air to escape so they're not rebreathing carbon dioxide. So that's why it's called non-rebreather. Your non-rebreather does provide 80 to 90% oxygenation. Your nasal cannula, or those nasal prongs, deliver about 24 to 44% of that oxygenation that you're giving to them. The liter flow per minute is 4 to 6. If your patient does not want to wear a mask, fighting the mask, go ahead and switch to the cannula. And there it is there. You're not going to see partial non-rebreathers in the field very much in Venturi masks either, but that's what they look like. They're kind of an outdated deal now. Your tracheostomy mask being put over a stoma or tube, you can absolutely do that. We turn the volume per minute down a little bit to 8 to 10 liters. There's your tracheostomy mask. If you don't have a tracheostomy mask, you can use a pediatric mask, and it'll fit right over that pretty good. If you have children, we do have non-rebreathers that are pediatric and infant in size. If you have a child that's going to fight that mask, you can do what's called a blow-by. So hold the tubing, or hold the non-rebreather mask a couple inches from the face, and at least they're getting that oxygenation. If they allow mom to hold, they might allow mom to do that. So make sure you utilize your parents when they're there. So special considerations, things that make our job a little harder. Facial injuries, bleeding is going to require frequent suctioning. So anytime you're doing airway management, guys, you should make sure you have your suction device with you. Airway adjunct, or even an ET tube may be needed. So if you've got somebody that's really having a hard time, you're worried that you might lose that airway, don't be afraid to call ALS. I'd rather have you call us and be able to come in early versus chasing an airway. Obstructions, remember your suction units can't really remove solid objects. You're going to use your McGill forceps and that laryngoscope if you have to. Abdominal thrusts, don't forget about those. Chest thrusts, finger sweeps to see if you can get objects out. Dentures, leave them in place. Okay, if they are dislodged or they're dropping or they're creating a problem, then you need to remove them. Your kids, tongue takes up more space in proportion to the rest of the mouth. You got the trachea that's softer. The head is proportionately larger. Your chest wall is softer. So And kids' oxygen burn through rate is twice ours. Watch especially when you're bagging, watch your pressure. Be very careful, only to chest rise. You don't need to have that much, the littler people are. This FROP device, or flow restricted oxygen power ventilation device, I'll show that to you during skills. It's one of these devices that is pretty outdated now because we have CPAP that kind of does the same thing, but kids, you can't use them on. Make sure you're using the proper size masks, bag valve masks, nasal cannulas according to your age. All right, and the last topic we have is assisting with these advanced airways. Before we place a tube, we usually have a basic airway in place. Ventilating is going on while we're preparing our equipment to intubate. You may be asked to help what's called a burp maneuver. So the burp maneuver is finding that cricoid cartilage, okay, that Adam's apple, and you're going to just press the thumb and index finger up and gently to the right, the patient's right. And what that does is it brings the vocal cords into view a little bit better for us when we intubate. Once we get that tube through the larynx, we're gonna fill it. We're going to they might have you hold it while they anchor it. And once that tube is secured, they can become dislodged relatively easy. So we got to be pretty careful once we intubate, making sure that that tube doesn't get disturbed. Ventilating once every 6 seconds, just like you would with any other device. Make sure you hold that tube and you ventilate. We do not want it to dislodge. We have a trauma intubation. You might be doing inline stabilization, and paramedic will come right across you, try to see if we can tube the patient without manipulating or moving the neck too much. So here's your critical thinking question I'm going to end with. You are on a call. You get a female patient. She's semi-conscious, so probably pretty altered. Respiratory rate is 7 per minute. She's pale. She's got cyanosis around the lips going on. Is she in failure? Yes or no? If so, what signs and symptoms indicate this? And do you think this patient needs ventilatory support? And that will end chapter 10. I'll leave you thinking on that one.